Okay, good evening, everyone. Welcome to our online meeting. A few points of housekeeping before we get started. My name is Louise Gaston. I work with Evolve Solutions Group. We undertake some administration services for several dental societies, and we're hosting this meeting this evening. Before we get started, to let you know that all attendees will be joining on mute for the session, and we'll be using the chat and the Q&A in the online meeting for any questions or comments from attendees and to provide web links throughout the presentation. In order to earn the 2 CE credits for the meeting, attendees must join using a computer, laptop, or smart device. That does include a smartphone, but if you're just calling in by phone, you won't be eligible for the credit. And I'm going to hand over the meeting to Dr. Tanya Tran. Thank you, Dr. Tran.
Thank you. Welcome everyone to our webinar this evening. If you are a new member, dental student, or guest dentist, and this is your first meeting, welcome. If you're a staff member attending, we are glad you're here too. I'd like to start off by introducing Kevin Schilling, Advocacy Director at WSDA. And is he on this call yet?
Can you see me?
Yeah.
Yep, I see you.
Can you hear me?
Yep.
Well, am I good to go? Good to get started and say hi and everything?
Yes.
Okay, thanks. Thanks, Dr. Tran. Hi, everybody. So I am Kevin Schilling. I am your advocacy director, basically, for the government. So I'm actually here right now in Olympia because it is the inaugural ball this evening. So everyone, legislators, lobbyists, the governor, everyone is here wearing suits and ties and tuxes uh, to celebrate the inauguration. It's the first time since 2016 that we've had an inaugural ball because of COVID and everything. So it's super. There's spotlights. I'm looking out by the office window and there's spotlights, which I think is crazy. But anyway, so you are the first group of people I'm telling this to because this is a very exciting situation we have going on right now. We have the biggest bill in the history of the Washington State Dental Association being considered by the legislature this year. It is a dental benefits reform bill. It contains a loss ratio of 85%, a taking away of same-day denials, uh, an inclusion of getting rid of virtual credit cards, and out-of-network reimbursement parity. And we are working with the insurance commissioner on this, but we have just finished getting signatures for our bill, and we are very excited to drop our bill tomorrow for the Senate bill and a House bill. We've never had this before. This is the first situation of dental association history where we have had these two companion bills dropped at the same time with the similar amount of sponsors. We're very excited about it. And you're going to be huge in supporting this effort when you come to DAD. So hopefully you've already signed up and registered for Dental Action Day. That is March 30th. And the day before, the reception, March 29th, is the evening before. And you're either spending the night or you're coming down on the 30th. But we are very excited to have you all there soon in 2 weeks. 1 week? Yeah, 2 weeks. To come down to Olympia to lobby on behalf of this big and exciting dental benefits bill. The other thing we've been working on is a workforce development bill around allowing dental assistants to do preventative work. Right now, as you all know, there is a massive workforce shortage in dental clinics, and that has to do significantly with a shortage of hygienists. Our workforce bill would allow dental assistants to expand their scope to do preventative work on already healthy, clean teeth so that hygienists don't have to do that and can expand their scope to go higher. We've been working with the Dental Hygiene Association on this. They are supportive. They are interested in making sure that this workforce bill works for them. And we ultimately want to bring something to the table that is basically has us and the Hygiene Association in agreement on next best steps. I'm happy to go into depth on either of those a little bit more or explain our advocacy efforts in greater detail if you have any questions. But we are very excited about this dental benefits bill, and we have been working very, very to get a winning group of legislators signed onto it, and we have done that, and we're really excited to drop it tomorrow. You're the first people I'm telling that to. You're gonna see it. You're gonna see it officially dropped tomorrow in the legislature, and there'll be a hearing on it and everything. It's fantastic.
Thank you so much, Kevin. Did we have any questions for Kevin before he leaves us?
No, there are no questions in the chat.
Well, thank you so much for sharing those news. We're excited about this session.
Dr. Tran, it's so great to see you running the meeting too. It's fantastic. And just to tell everybody, Dr. Tran came to one of the opportunities to meet with. Oh, now I'm forgetting. Did you meet with Patty Cooterer or did you meet with Congressman
Yeah.
Rick Larson?
Yes, I did meet Patty.
Okay, so she came to one of the events we had in Snohomish County to sit down with the now insurance commissioner when she was running for insurance commissioner. And I'm telling you, these events, these were super important to get the insurance commissioner on our side and support us in our efforts. So Dr. Tran came with maybe 10 other dentists, 10, 12 other dentists, but we did that 5 or 6 times across the state. We helped Patty Cooterer get elected as insurance commissioner, the first new insurance commissioner in 24 years. And last week, we had a meeting that she set up and moderated between us and Delta Dental, where we were able to be in a room with the public insurance regulator to moderate and say, all right, providers, what are your issues and how can we fix them? And in 24 years of the previous insurance commissioner, who's elected by the state to regulate insurance, we have never once ever had that. And the first week of her being in office, she held a meeting to say, insurance, you've got to fix these problems. So that's very exciting.
Yeah, very great news.
And so thank you, Dr. Tran, for coming to those in the summertime. It paid
Yes,
off.
of course.
Paid off.
Thank you.
All right, well, I will see everybody at DAD. Thank you so much for letting me come for a few minutes. Sorry I couldn't stay longer. This is happening tonight. This is the first time in almost 10 years that there's a state government inaugural ball, so can't miss that.
Yeah, hope you have a great time.
All right, thanks everybody.
Thank you. Next, I'd like to introduce our sponsors. Thank you for sponsoring our meeting. I'll just list everyone out and then you'll each have a couple minutes to speak about your business. First, Columbia Bank, Lynn Nelson, Merchant Advocate, Cheryl Dunham, and Dentsply Sirona, Aaron Gallegos.
Well, thank you very much. We're very happy to be able to sponsor Snohomish County Dental Society. We appreciate the opportunity, and we are just here when you need us. We certainly, I put up some bullet points of all the different areas that we cover. I would say that one of the things that really helps us to stand out as a trusted lending partner is that we are full service. We're very much about relationship. And so once you begin to bank with us, and if you need lending or what have you, one of the nice things is you have full access to our wealth management department and private bank. And so we currently offer a complimentary financial plan for our clients. And we also can point them into different directions as far as we have a home loan that is especially for our clients. And we do all of the usual things such as acquisition and expansion loans and commercial real estate. So anyway, I know we have a lot of partners out there or clients out there that we work with already from Snohomish County Dental Society, and we just our door is open and would welcome new clients. So Happy New Year, and have a great meeting.
Thank you. So I am Erin Gallegos, and I am the Dentsply Sirona Preventive Rep. And we've actually had some exciting changes that I'm going to go over in my presentation today on what other services that I can provide to an office. But you probably know me for the last 20 years. If you've seen me in your office, is I'm typically the Cavitron rep. That's how most people correlate me to. I think this might be my third time that I've been invited back to this meeting, so I appreciate that, and look forward to seeing everybody in the new year.
Great. Hi, my name is Cheryl Dunham, and I thank you so much for having me. I work for a company called Merchant Advocate, and Merchant Advocate is a little unusual in that we analyze your credit card processing rates, looking to see if we can save you money. We do a premier analysis of your statements when we get them, and if we can save you more than $200 a month, you're a candidate to work with us. We then would negotiate with your existing credit card company. You don't have to switch your processor or your equipment. And for any of you that are integrated with your software, this is very important because you can't just switch to a different processor. Okay, next slide, please. So basically, we not only negotiate with processors, but if you're processing through your bank, we can help you by advocating with your bank as well. We're looking at your pricing. We're looking to see if you're PCI compliant. We're looking to see if there's ways that we can help you optimize the way you're processing and save yourself money. And also to see if you were properly coded when you were entered into your merchant services statement. You may or may not know that on your statement, typically in a month before they increase your rates, there's fine print that talks about the fact their rate increase is coming. Quite often, we know you don't see the statement, so that's something we look for you. So very interested in seeing if we can help you save money on your processing. Again, this is not about switching you to a different company or having to get new equipment. This is about saving you money with the company you're working with. A great way to add to your bottom line and requires very little of your time. So on the next slide is my calendar and my contact information. Feel free to scan that QR code. You can set up an appointment with me and send me your statements if you'd like. We do ask for 3 months of statements to get a feel for kind of your different volumes. But I welcome the call, and we'd be glad to discuss this with you, even if you're not interested in sending the statements at this time. So thank you, and have a good night.
Thank you again to all our sponsors. Next, I have some meeting announcements before we begin our program. First, this class will be recorded, so you can access the recording from the SCDS website. The recording will be available until January 31st. CED certificates will be distributed to the participants of both the virtual and recorded class after that time. Our next meeting will be in person at Sean O'Donnell's in Everett. That will be Wednesday, February 19th from 6 to 9 p.m. As always, the meeting and dinner are free for all members. WeO Media founder and CEO Corey Rinaldo will be speaking on reputation management with a digital age perspective. Corey will discuss how you can foster and manage your reputation with advanced technology and simple internal systems. Best practices for interacting with online reviewers will be explored in detail. You can register for this online through the website or responding to the email. Also, mark your calendars, plan ahead to volunteer for Toothapalooza in 2025. It'll be on Friday, February 21st at the Imagine Children's Museum in downtown Everett. This will be our 18th annual event. Please contact the SCDS office to volunteer. And then lastly, as Kevin talked about earlier in the meeting, Dental Action Day will be Thursday, January 30th in Olympia. Please arrive the night before and participate in the legislative reception Wednesday, January 29th at 6:30 at Anthony's Home Port in Olympia. Registration for Dental Action Day closes January 16th, so please go to the WSDA website to learn more. And so that's it for announcements. Next, I'd like to introduce our speaker. Erin Gallegos has an extensive history with the Dentsply Sirona Company and has been an employee since 2004. She works as the Executive Region Business Specialist Preventive, focusing on the infection control aspects of dentistry. Ms. Gallegos is a member of the Organization for Safety, Asepsis, and Prevention, OSAP, and OSAP Dale Foundation Dental Infection Prevention. In 2020, Erin earned the OSAP Control Certificate. Her knowledge helps the dental clinician become more efficient in their daily duties, plus ensuring they're following CDC and state dental infection prevention guidelines and laws. Erin also educates the distributor channels on these topics. Erin was a competitive figure skater, winning national regional championships in the 1990s, and brings the focus and energy she learned in her athletic career to her work in the dental industry. This is the 4th year Erin has served as our presenter, and we are appreciative of the support of Erin and Dentsply Sirona.
Thank you so much. I'm going to share my screen here. Okay, can everybody see it?
Yep.
My people that are okay, cool. Because I know nobody else is going to say anything. Okay, so let's get going here. So, like she said, I have now been with Dentsply Sirona. This is going to be my 21st year, and I was with the preventive division. And OSAP has now changed its name to ADS. So we'll talk about that in a little bit. But when everybody else was kind of shut down and we were all twiddling our thumbs and whatnot, I took the opportunity to go a little bit deeper into this whole infection prevention thing because of the Washington state law that was changing, right, with DQAC and stuff. And I also have another person on this slide, which is Allie. So Allie Mitchell was our restorative rep. She's been with Dentsply for about 2 years, and she and I have been working the Snohomish County and the King County area for the last 2 years together. She is a dental hygienist as well, and she also was an instructor at Shoreline. And so a lot of clinicians recognize her face or kind of know her. And the reason why I've put her on this is because this year Dentsply has merged some of our divisions. So one of the first slides on that opening part talked about, it had like the different divisions of Dentsply, and like I was the preventive rep and Allie's the restorative rep. And so now we've merged these two divisions. And so now we're called Chairside Solutions Specialist. And Allie and I specifically cover the Snohomish County area. I also cover Whatcom, and we also do King County together. But what that means to offices is now you have one point of contact for infection control products, restorative products, and the dental hygiene consumables. And so we work in collaboration with the distributors as well. So this is something that's new for Dentsply. This is actually how the Canadian marketplace has operated, and they've been piloting this type of a streamline in the southern part of the United States for the last 2 years, and it's gone really well. Clinicians and offices appreciate not having so many Dentsply reps. So this is something that you'll be seeing more as the year goes on. So this is kind of an outline of how it used to be, how there was different divisions. And so the preventive division and the restorative divisions are going to be merged together. But that's not what you guys came here for. We want to talk about infection control stuff today. So today we're going to be talking about what Washington State requires as far as infection prevention. I do these presentations a lot in offices, and so I always want to make sure that people understand that I'm here to present the information. I'm not here to judge what you're currently doing. I'm here to provide tips and maybe some insights on maybe how you can improve some team collaboration that goes on. And some of this might be review for some of you. Some of it might be a new little nugget that you're going to take away. What I hope from tonight's meeting, because everybody's at home and you're not with your team, is that maybe I might say something today that might spur something that you're like, oh, I don't know if we do that correctly. And it might start that conversation back with your team. I really emphasize that everything has to be done as a team effort. So what is DQAC? DQAC is the Dental Quality Assurance Commission for Washington State. We're going to be talking a lot about this and also CDC guidelines today. These were the changes that went into effect back in 2021. And I know that seems like that was a couple years ago. This is like old. This is still new information for most offices that I interact with on a daily basis. They don't realize that this has actually happened and that these are the recommendations from the state. And most of it are going to be based on best practices that were based from CDC guidelines. So some of the highlights that I talk about is going to be like, you need to have written policies for your staff. You need to have staff training. Sterilization of slow speed motors was like such a big topic when this went into effect. Wrapping your cassettes or having everything in a pouch was kind of a new thing that shocks people, like no longer putting loose instruments into a statum. And then obviously identifying your disinfectants and using a high volume evacuation. Waterline testing is a huge thing that I'm still finding that a lot of clinicians are like, maybe they're doing the waterline testing, but they're not doing all the things that need to be tested. So this still has a huge learning curve because I am the Cavitron rep. That comes up a lot with the Cavitron. So this still has a big learning curve for most clinicians. So why did all this happen? Why did Washington State start diving into all this stuff and, updating their WACs? The last update to the Washington State infection prevention rules was back in 1995. And just like the world, everything happening in the world, but also in dentistry, can you imagine like how you used to do dentistry back in the 80s versus now? Like things have changed. We've learned more. So it was appropriate to kind of for the state to do a deep dive and to look at some of our rules and realize that they needed to be updated or the wording needed to be changed. And remember that the purpose of all of this is to protect the well-being of the patient. So a lot of times I get asked about, we did our OSHA training or WISHA training, and it's like that's more about the employer-employee relationship. And so today we're primarily talking about mostly about that clinician to patient relationship. So we all know kind of what CDC is, right? So CDC is the recommendations. We have the FDA, which is the Food and Drug Administration. FDA is what regulates my company, like Dentsply. When we make a product and we have a directions for use, the directions for use is an FDA regulated product. You also have the EPA and then our OSHA WISHA stuff. So OSAP, like I said, changed its name. So now it's called Association for Dental Safety. I like to say, if you've never heard of this organization, I really encourage you to check out their website. I view it as very similar to CDC, but it's only for dental. So if you guys remember, like during the pandemic and you were looking for COVID type regulations and rules and guidelines, and you would go to the CDC's website and it was just like this deep dive on like, oh my gosh, how is this even like relative to dental? So with the ADS, the formerly OSAP, that it's only dental. So you type in something that you have a question about for infection control for dentistry, and it's only going to talk about dentistry type items. So it's a great resource. So if you've never gone to the Department of Health's website, they have all these rules on there, and this is what it looks like. This is the format of the text. It's very dry. It's lots of small print. So we're not going to look at this kind of stuff throughout this presentation. But I do want to just highlight that these are the main things that we have to cover in this training today. And it talks about how a dentist does have to have the written policies and procedures, and that they do need to review these annually. So it's important that whoever is in charge of your infection control at your office, have that be a clinician and a dental assistant, or just the dentist, or even maybe an office manager, that they have these rules for all of these items typed up in some sort of a workbook or a booklet would be appropriate. So why is it important? I'm going to do a little video.
What are you doing? What? Did you just double dip that chip? Excuse me? You double dipped the chip.
Double dipped? What are you talking about?
You dipped the chip, you took a bite, and you dipped again.
So?
That's like putting your whole mouth right in the dip.
Right, do we all remember this? So the risk is real, right? So we can look at it from a patient's perspective, or we can look at it from a clinician's perspective. So in dentistry, it is rated one of the riskiest jobs out there. So dental hygienist, this is based on Business Insider. Dental hygienist is the riskiest job. Dentist is number 2. Dental assistant is number 5. I think a vet tech is also in there, like number 4 or something. But you are exposed to disease and infection on a daily basis. So it's important that we're protecting ourselves, but also those patients. So RDH Magazine did a survey with patients that said, hey, have you ever left a dental practice because they felt like their infection control wasn't like up to par? So 24% of patients said yes. And when you think about just the general patient population, they don't know what the rules are. They don't really know what you should or shouldn't be doing. And they're kind of assuming that somebody's kind of monitoring you. And so that's why these guidelines are put into place to kind of make sure that we are protecting the general public. So when we think about why infection prevention is important, it's to navigate through all these infection prevention protocols that need to be followed. So these are the microorganisms that are relevant to the dental settings. There's different ones on here. MRSA, I've had a friend get MRSA. To me, MRSA is like one of the scarier ones because it lives on a countertop for 7 months. So it's important that we are taking care of all these microorganisms in an appropriate way. And when you think about the chain of infection, it all starts with you need to have an adequate number of pathogens, right? Then you need to have some sort of a reservoir or a source and a mode of transmission. Like something has to break here for it to not continue to spread. I also like this diagram when I'm talking to offices and their team, right, the staff, is because we need to make sure that whatever the protocol that you set in place in an office, that you actually have it set up so everybody understands. Because if one person isn't on board with following what the protocol is or the rules are, then you might as well just not have anybody do anything. So it's really important that everybody's on the same page and everybody buys into it. So the modes of transmission, we have our direct contact, we have our intact or non-intact skin in direct contact with blood, oral fluids, or other potentially infectious patient materials. You do have your indirect contact with the contaminated object, instruments, operatory equipment, or the environmental services. You have your droplet transmission. So that's going to be like contact of the mucous membranes of the eyes, nose, or mouth with droplets. And that's going to be containing microorganisms generated like coughing or sneezing. Then you have your airborne transmission. So that's going to be the inhalation of the airborne microorganisms that can remain suspended in the air for long periods of time. Dental healthcare workers are at a particularly risk of bloodborne pathogens due to the exposure of blood and other potentially infectious materials during a dental procedure, or instrument reprocessing, or just operatory cleanup. So one of the first things that was on that original list that we have to cover is the hand hygiene, right? So let's just dig into these rules and maybe some best practices to accomplish all this. So according to the CDC, you need to be washing your hands, right? So this is going to be your number one defense against pathogens. And then your PPE, obviously wearing gloves. Hand hygiene is the single most important factor in preventing the spread. Cross-contamination is promoted by poor hand hygiene. So when we think about what's going to be the good, better, and best, good is plain soap, like soft soap, dial soap. It's good for reducing bacterial counts, antibacterial. It's good against household germs, but it's not that great against pathogens that you're seeing in a dental practice. Better would be an antimicrobial soap because it's antimicrobial and not antibacterial. It's an intermediate level of protection. Best is going to be that 60 to 95% alcohol-based hand rub. It's providing activity that prevents or inhibits survival of the microorganisms after the product is supplied. However, not all hand rubs are created equal. I think one of the most important things about using like a hand sanitizer is the hand sanitizers are activated by the actual rubbing motion. So if you just put a bunch of hand sanitizer on your hands, but you don't rub it around until it's dry, it's really not doing much for you. You need to actually be rubbing it. And it needs to be an over-the-counter. All of these items need to be non-over-the-counter. So like over-the-counter type products aren't going to be what you're needing in a clinical area in a dental office. So 9 to 12 seconds is the average total time a clinician spends washing their hands. However, they should wash it for like 30 seconds of lathering time. The total process should take 2 minutes to wet, lather, rinse, and dry. If you have somebody maybe that you recently hired in your office or they're not super familiar with the process of washing hands in a dental facility, there's all sorts of videos and like reminders that you can show them. Hand hygiene is indicated after the contact with a patient's intact or non-intact skin, or if a clinician has contact with potentially contaminated objects. So hand hygiene does need to be performed whenever the hands are visibly soiled, before donning and after removing gloves, before donning new gloves if they're swapping out during a procedure, and hands also need to be cleaned before leaving the operatory or the lab. So we need to be doing some PPE as well. So this is about, remember, this is about the riskiest jobs, right? You have one of the top riskiest jobs out there. So we need to make sure that we're protecting ourselves. This section of the law talks about you need to be wearing gloves, right? Pretty basic stuff. They need to be new gloves, but you also need to be using protection that's covering your mouth, nose, and your eyes. So CDC recommendation and the OSHA regulations, not only do you need to protect yourself, but you also need to protect yourself from respiratory infections. So not just ergonomically, but also respiratory stuff. So OSHA makes these, so WISHA for here, right? Makes these recommendations and requires the PPE be done. Face masks and protective eyewear must be worn whenever there is potential for splashes, sprays, or spatter containing blood, saliva, and other bodily fluids. Face masks will also protect you against the aerosol and airborne microorganisms and particles. But these need to be changed between each patient, and they need to be removed in the operatory. So one of the things that I've been seeing more recently is gloves still being on, masks still being on while the clinician is walking the patient out to the front. And then they're touching things at the front desk. Maybe they're handing the file over to the front desk office person. So it's really important that we're removing these things in the operatory. I think that during the pandemic, we got really educated on appropriate masks. Prior to the pandemic, this slide would have probably been really foreign to many clinicians, where the masks are rated by ASTM levels. So there's an ASTM level 1, 2, and a 3. And then obviously you can do your N95 masks and whatnot. I would say that most clinicians now understand this and have started to protect themselves by wearing the ASTM level 3, which is going to be the maximum protection. Now, there can be some breathability challenges when you get to that level. And so it's important that maybe you try different brands of masks and find one that fits your face appropriately. But a level 3 mask is intended for crown preps, implant placements, the use of ultrasonics because you're creating an aerosol, air polishing, periosurgery, and complex oral surgeries. And just in case you didn't know, ASTM stands for the American Society of Testing and Materials. It's a nonprofit organization that developed the standard testing methods by the consensus of volunteers through manufacturers, users, and others. The box of your mask will proudly demonstrate on there like what level it is. So if you're not really quite sure, it probably means that the mask wasn't rated. So donning a fresh mask for every patient, replacing it after 20 minutes if it's heavily soiled. Since the mask is intended to protect oral and the nasal, it's really important that it fits well across the bridge of your nose. And you need to make sure that it's looped under the chin. It seats under the chin. What you don't want to be doing is having it like hang down from the chin, or you're having it dangle from like your ear. When removing a face mask, first remove your gloves, which are the most contaminated. Do not touch the front of the mask. It's considered to be the next most contaminated. And then the mask should be removed by handling the ties or the earlobes, starting from the bottom and then the top tie or band. It should then be lifted away from the face and discarded in the waste receptacle without first placing it on any sort of service. Immediately after this, hand hygiene should be performed. So it's important that we're not reusing masks, coming to the lunchroom with a mask on. Everybody's going to be getting a fresh mask. There are some masks that have chin straps on them. This shows over on the right. If you guys remember the video, well, depending, I guess, how long you guys have been in dentistry, but if saliva was red, right? So this shows like that was actually done by OSAP, that video, and now they've recreated it and made it a little bit more modern. That video was, it's kind of funny to watch because there's like a phone in the operatory and they're wearing like short sleeves and, but you know, it was made, I don't know, 25 years ago probably. So not everybody in your office can wear the same brand of mask. It needs to fit their face appropriately. You shouldn't be twisting the ties around your ears to make it fit better, because that's just creating like a gap on the side. The rules also say that you need to be wearing, the patient needs to be wearing some sort of safety glasses. The lens frame need to be covering the whole eye area, and also the clinician as well. So, and then they need to be cleaned in between each patient as well. So your gloves prevent the direct contact with blood and saliva or potentially contaminated objects. They minimize the risk of disease transmission from patient to healthcare. There is a case documented where an oral surgeon transmitted MRSA to 2 different patients during the oral surgery procedure 3 weeks apart. The patient had been unaware that he was carrying MRSA, which may have been acquired during a recent hospital stay. Among the findings was the requirement for improved infection control, including the routine use of gloves for patient use. So I know that, you know, years and years and years ago, we didn't wear gloves as a clinician, but now it's pretty standard. If the integrity of a glove is compromised by tears, cuts, or punctures, it needs to be changed as soon as possible. They should not be washed in between, right? They're disposable. You're not going to be putting on multiple gloves. They're going to be removed after patient care. Hands should be immediately washed, and then hands should also be washed before putting gloves on. But wearing gloves does not replace the need for hand washing. What's also important is that you're using appropriate types of gloves, right? So for routine care and examinations and non-surgical procedure, the non-sterile single-use disposable medical gloves are recommended. Then we have our surgical procedures, And those are going to be your sterile single-use disposable gloves should be worn. Sterile surgeon gloves are more rigorously regulated by the FDA and may provide a greater protection if the exposed to blood is anticipated. The fit of the glove should be snug, but not tight. And gloves that are too tight may result in hand fatigue and also might be stretched too thin and have a greater loss of integrity. For instrument reprocessing and operatory cleanup, the use of heavy-duty utility gloves that are puncture and chemical resistant is recommended. When exposure to the bloodborne pathogens is possible, puncture resistance gloves must be worn. Unlike patient care gloves, heavy-duty utility gloves can be cleaned and disinfected for reuse. Some may even be autoclaved number of times, and the manufacturer of the heavy-duty utility gloves can advise you on the reprocessing. I know that they are cumbersome and annoying, but this is about protecting the clinician for the most part. Okay, this next section is long, and I divided it up to make it a little easier to understand. So we're going to talk about sterilization and disinfection along with environmental infection prevention control. So we first kind of look at what does it say? What I find interesting about these DQAC rules is that the spirit is CDC guidelines, okay? But CDC guidelines is not the law or the rule. But the spirit that DQAC went into this is by looking at CDC and then kind of tweaking it a little bit. Some states, for their dental rules, the state will just say follow CDC. I went to every meeting of these DQAC meetings down in Olympia, and they were really adamant on, they didn't want to just say CDC, because then if CDC changed, then all of a sudden the law changed. So they really wanted to specify. So you'll find if you actually take the time to read this document on the Department of Health's website, that it says, when in doubt, basically follow CDC guidelines. That's kind of like its backbone. And then it added some very specific things. So you'll see here, it says follow CDC guidelines. Then it talks about slow speed motors and handpieces. So they did give grace of a year and a half after these rules went into effect that offices needed to start following the protocol of autoclaving slow speed motors. You'll also find that this next section talks about critical, semi-critical, and non-critical. This is really important because you will find that this document does not name every single dental item out there and how to reprocess it, but it does call out what does critical mean, what is semi-critical, and what is non-critical. And if we recall back from school, they talk about Spalding's classifications. And so I get a lot of phone calls on, does this have to be steam autoclave? Is it okay if I wipe this item down? Where does it say this in, the DQAC and the Washington state law? And it's not going to call out every item. And that's where you have to go back to Spalding. So most instrument cleaning and disinfecting and sterilization should occur in a designated central reprocessing area. So in the cleaning area, you need to have your reusable contaminated instruments where they're received, sorted, and cleaned. Then you should have a packaging area, and then you should have the sterilization in the storage area. And the other thing that this document says multiple times is follow the directions from use from the manufacturer. Because like I stated earlier at this presentation, those documents are FDA regulated. So if you're following the directions for use, then you're good. So it does talk about how you need to be autoclaving the slow speed motors. And it's important to understand what is a motor, because every manufacturer has different pieces that are motors or a coupler. So couplers don't have to be autoclaved, but the motor does. And I'm not going to get into the whole reasoning why. If you want to know why, you can reach out to me separately. And then it also addresses battery operated hand pieces. There are now several different companies on the market that have battery operated. This tends to be a touchier topic when we get to these slow speed motors. And I do want to point out that back in 2016, CDC guidelines published a summary document. If you're watching, it looks like this. It's maybe 10 pages. It's not very long. It's not anything that was changed from the original CDC document, but it's in a little bit clearer language. I call it the Cliff Notes. And so it talks about slow speed motors in this document, because in the prior document, it kind of just grouped hand pieces all together. It didn't specify high speeds, slow speeds. The wording was vague. So this is a really good document to look at. So it does say that the battery operated, this is back to the DQAC rules, that battery operated ones don't have to be autoclaved, right? But you need to follow the manufacturer's instructions. This is really important because you'll find every battery operated handpiece, most of them are Profi handpieces, their reprocessing documents vary dramatically. So it's important that you read them if you have a battery operated one in your office, and make sure that you're following it. One, not just to keep the patient safe, but also to make sure that your investment in these pieces of equipment are worth it in their longevity. You don't want to be spending a bunch of money on stuff and then have it like not last as long as you were expecting them to. So this section talks about reusing dental equipment according to the manufacturer's use. Did I just say this like a minute ago? It talks about this in a lot. It also talks about disposable and single-use items. So if an item that you open up is in a box or packaging and it has this number on it, that means that this is a single-use item. It's not to be used twice. That's really important because you'll find that you maybe have been autoclaving something that didn't melt and it seemed to still have its integrity, but it was not FDA regulated and cleared to be used a second time. So unfortunately in dentistry, we have a lot of waste. CDC recommends the use of single-use disposable items whenever possible because it takes out the guesswork on how to reprocess stuff. So single-use items that are not heat tolerated, typically made of plastic or inexpensive metals, they should never be reused. More importantly, most instruments or other items are difficult to clean, which in case sterilization could be compromised and contamination may remain an issue. This section, again, we're still talking about sterilization and reprocessing. It talks about how you have to bag or wrap your contaminated instruments and then put them in the sterilization. It also talks about how you need to be opening up these packages or cassettes as close to the time of the procedure as possible. I remember this conversation at these meetings where they have drafts when they do these wordings, and it would say like, you need to open it up in front of the patient. And then of course, somebody on the committee was like, well, that sounds too dramatic. I always find it interesting to find out like, what's the spirit? The spirit is they don't want you setting up a tray, maybe at 4 o'clock, putting a bib over it, and then coming in, and using all those instruments on the patient at 8 a.m. or setting it up during lunch. They want to be able to demonstrate to a patient that these items have gone through the autoclave. When it talks about bagging or wrapping, I think here in Washington State, this is also a little bit of a touchier subject because statums are very popular. And we like statums because you can put items in loose and it's fast. And so they want everything to be in a pouch or wrapped and to come out and be able to then sit in a drawer or go on a tray and stay wrapped so you can prove that it actually went through. So you need to be able to verify that sterilization parameters with the chemical indicators have happened. And that's where you have your special tape or your pouches. This also avoids the risk of confusion between things that have been processed and things that have been unprocessed. Instruments will remain sterile until the packs are open, unless obviously the packaging has been compromised. So it's also important that you're not putting a bunch of things in a pouch together that you're not going to be used together. So once you put it in the pouch, then those items stay in that pouch. So the dental unit water quality, this is really important that we're like testing our water lines quarterly. I think that waterline testing can be confusing for some clinicians because we have to, again, remember like, why are we testing? We're not testing to find out if the water's okay. Like, is it good water? Like you got the water out of the tap, or you got the and you put it in your bottle, or you buy distilled water. That part doesn't matter. It's once the water has traveled through the variety of dental lines. So through your dental chair delivery unit, through your Cavitron tubing, wherever the water is traveling is typically where all the bacteria is getting picked up. So they did give grace period of 1 year after this law went into effect. So effective December of 2021, then you needed to have your water lines testings need to be done quarterly. And so that means that every single item that produces water in a dental room, in a operatory, needs to be tested. So I think that most offices that have implemented this are doing high-speed handpieces and air water syringes, but many of them are forgetting to do the Cavitrons. They do allow you to have a pooled sample. So you can test up to 10 different water lines in an operatory. I actually had a little meeting with ProEdge and I tested one of my Cavitrons and it failed. So I think it's really important to kind of understand how this works. This is the quick pass from ProEdge. I had never tested before, so I wanted to actually do it and follow the directions. And it's like you have to have it lay upside down and have it be 24 to 36 hours and don't touch it. And there's a process, but it was pretty easy. So just realize that as well. So why do we care? Hopefully nobody's eating dinner right now and looking at this little picture. So the dental water lines, they promote bacterial growth and development of biofilm due to the lumens and inconsistent flow rates. The water is stagnant overnight. And so that's why, again, I am the Cavitron rep. So I know a lot about Cavitrons. You need to be doing flushing in the morning with your Cavitron, with your dental chairs, because the stagnant water that's been sitting there overnight. Dental healthcare professionals and patients can be placed at risk of adverse health effects if the water is not appropriately treated. And this can happen fast. Like if you have bad lines, this stuff can happen within like a couple hours, maybe days, but it happens fast. So on your Cavitrons, you need to be checking your water filter. You need to be purging first thing in the morning. There's lots of things that you should be doing on your Cavitron testing. And then if you've never tested the Cavitron, you might want to do a shock first. Like save your 20 bucks on the ProEdge water test kit and do a shock first to make sure that you're going to pass. In the event that you have an unacceptable level of water, you failed, then you actually need to shut down for the day, like whatever operatory that is, and you need to remedy that. And you also need to be taking, keeping any sort of file if you've had any sort of like plumbing done or whatnot in your office as well. Maintain documentation. We're still on sterilization and disinfection. So you need to be using a high volume evacuation whenever you are being exposed to aerosols. This came out, they were talking about this prior to the pandemic, like 2 years prior. Then the pandemic happened, and then, you know, everybody was hypersensitive to aerosols. And then I feel like we kind of went backwards again. So as a clinician, you're wearing a mask, but the next patient that comes in is not wearing a mask. And that's where this high volume evacuation is really important. So it does state in the law here that a saliva ejector does not qualify as a high volume evacuation. And high volume evacuation means that it needs to remove debris, aerosols, and liquids. So during dental procedures, bacterial aerosols increase by 5%. Contaminated aerosols can spread nearly 8 feet. So imagine if you're in an open bay operatory without walls or dividing areas. And the most common reason for missed work is respiratory infections. That's kind of an interesting correlation there as well. So it's about protecting yourself as much as you can, but for the most part, you're wearing a mask. It's that next patient that's coming in that's being exposed to the aerosols. Like we talked about before, you need to be wearing a face mask to protect the clinician, but the high volume evacuation reduces the aerosols and bacterial aerosols that they're exposed to every day. And we can't see this stuff. This stuff it's like the invisible issue. Both CDC and the ADA recommend that aerosols and spatter be minimized. So by using a high volume evacuation, you'll be able to capture 98% of what's going on as far as the aerosols. There are so many different items that are out there. You can just use a regular high volume evacuation. Dentsply has this product that has a mirror on it. Some people take a high volume evacuation and they have cut it to make it shorter, called a milkshake straw. I think that anytime you try to implement something new, it can be a challenge. But if you stick with it and try to adapt to it, you can make it work. Something that also came up, I feel like more during the pandemic, because everybody was using their high volume evacuation, is they felt like maybe their evacuation system wasn't working very well. That has a lot of varieties to it. But one of the reasons is that you need to be cleaning out your evacuation lines on a daily basis. And there is a system, like what operatory you do first matters. You want to start at the operatory that's furthest from your mechanical room and make your way towards it. But there's also, you need to be using a pH neutral per the EPA rules. So there's lots of different products that are out there for that, but it's important to do every single room, even if the room wasn't used that day, because what happens is they're all daisy chained together. And so you need to make sure that you push, I call it sludge, sorry, you push it downhill and you don't make it stop at one of the rooms that wasn't used that day. There's all sorts of buckets that you can get to make this job a little bit easier. I do recommend that if you have one of your clinicians doing this at the end of the day, maybe buy him or her some cookies and appreciate them, because it's kind of a gross job. This section is going to talk about sharp safety. Again, most of this will probably be review for any of you that have been in dentistry for any sort of time, but it's important that we cover this. So during the instrument reprocessing, when splashing or spraying is anticipated, you do need to be using your PPE. Remember, we talked about that. So that's important when you're handling sharps as well. Ideally, a sharps container should be in every operatory, and sharps are disposed of chairside. When disposing of sharps, it's important to handle sharps one-handed when possible, and to make sure it's visually inspect the sharps container to make sure it has enough space for the sharp device. Capped needles, all-in-one syringes, disposable scalpels, they need to be placed in the sharps container. The sharps container is color-coded red. It's sturdy, puncture-proof with a closable lid. Do not reuse the sharps container. They need to be disposed in accordance with the regulations, the EPA, state, local, and do not place hands or fingers into the container to facilitate disposal of a device. Instruments should be placed in an appropriate container of the use to prevent injuries during transport. And occupational safety must be followed by clinicians to reduce the risk of sharps injuries. The handling of loose contaminated instruments during transport to the instrument reprocessing area is to be minimized. This section talks about the disinfection, right? So when we're talking about the high level disinfection and what we're trying to kill on the countertops, the chair, the walls, and whatnot. So there's actually two categories when we're managing environmental surfaces in a dental setting. We have the clinical contact, and then we have housekeeping surfaces. So clinical contacts are directly touched by contaminated items. This is high level. Housekeeping surfaces, there's no direct contact with contaminated items. This would be like the front desk area. It does state that a barrier protection can be used on small and large areas, but it's particularly useful for clinical contact surfaces with difficult to reach areas for cleaning and disinfecting, such as like dental switches on a chair. A new barrier does need to be placed between each patient. After each appointment, the barrier protection must be removed and discarded. Clean exam gloves or heavy-duty utility gloves must be worn while removing barrier protection. The barrier protection was intact during use and during removal. A fresh barrier protection can immediately be placed over the surface for the next patient. At the end of the day, all barrier protections must be removed and the surface is cleaned and disinfected. If the barrier protection was damaged or torn, the surface does need to be cleaned and disinfected before a fresh barrier is placed. Most of the time now we're using some sort of like wipe or a spray with a 4x4 or something like that. So you need to verify that the product is being used is registered with the EPA as a hospital disinfectant. So this is really important that it has some sort of like kill time on it for TB. It can't, we're talking clinical now, right? So it can't be stuff that we're using in our kitchen. That can be an item that maybe you want to use to wipe like the office area, but when we're in a clinical operatory, it needs to be something that actually has writing on it that it will kill TB. And it's a two-step process. So if it's a wipe, then we're wiping the surface first with the first wipe and then discarding it. Then the surface is wiped with a fresh wipe or disinfectant. Then the surface is left to dry until the indicated kill times are reached. So this is again important when you have a variety of different brands in your office. It'll say what the kill time is. Is it a 1-minute kill time? Is it a 3-minute kill time? Is it a 7-minute kill time? So it's important to know, especially if you end up like changing brands all the time, that the kill times are different. If it's a spray, the procedure is spray, wipe, and then you're going to spray again, and then it needs to stay wet. So it's really important that it stays wet for that kill time. If you have wipes that are drying out prematurely because the lids are being left open, or maybe you need to rotate the container, you need to make sure that it can stay wet for whatever that kill time is. Dentsply obviously has wipes. They're called Oxivir. Ours is a 1-minute wipe, but that's why it's really important that you know what the kill times are. And as you switch from brand to brand, you also should be doing a soap and water rinse so it doesn't discolor the plastics in your office, because every wipe has a different chemical in it. And that's why, again, back to the Cavitrons, you'll see Cavitrons that are all yellow, and that's because of that. This next section talks about basically your autoclave. And again, pretty review that you need to be doing your biological spore tests. What's really important is that to make sure that your autoclave is working properly, that you're not overfilling it. So all instruments must be cleaned by using the instrument washer or washing disinfectant or an ultrasonic bath. You have to follow the directions for use, whatever it says how to clean the debris off before you put it in the autoclave. Then you have your different types of autoclave, right? You have your gravity displacement, your dry heat sterilization. So you have to know what is the type that you have in your office, and then what are the directions for use state on whatever product you're trying to autoclave. And then you need to be doing your spore testing, and it's recommended weekly. And if you have a failed test return, you need to notify all the patients during that time of the fail. So there are a variety of different Dentsply Sirona infection control products. There are a variety of other brands out there as well. And I think it's just important to understand what they all will do for you in reading those instructions. But I think the biggest takeaway when you go back to your office is you need to identify a designated infection prevention coordinator. They need to familiarize themselves with the Department of Health's website where all these rules are posted, or reach out to me and I can send them to them. They should have some sort of a workbook that you guys can strategize with. You should review the full DQUAC document. There is a frequently asked questions about everything I just talked about, where they kind of cover some of the main questions that came up. If they are, I guess, a techie clinician that really likes to have apps and stuff, there is a CDC dental check app that they can download on their phone or on an iPad. Remember, I said there was the 2003 CDC guideline, and then there's a 2016 summary, which was the Cliff Notes. I would definitely have those printed out as you hire new clinicians. Have them read those. There is also a infection prevention checklist. I have these, so if somebody emails me, I can email them the PDF. The checklist looks just like the summary, same color, but it's a good little workbook. If anybody's watching the screen right now, it's a good workbook where you can actually answer questions about your own office, and it will kind of help you identify where your gaps are. And then you guys can have staff meetings where you talk about improving one thing at a time. I highly recommend that if you fill out one of these workbooks and you realize, wow, we have a lot of work to do, I feel like the best step is to attack it one by one. I refer to it like going on a diet. You want to go on a diet and you want to change your eating habits. If you try to like knock out all the candy and the soda and the alcohol and do everything at once, it normally only lasts for about a week. You got to like implement one thing at a time. And then you can subscribe to OSAP's website, which is still osap.org, but obviously they've changed their name. But they will give you all sorts of CE opportunities, training opportunities, news and infection control. It's they have great opportunities as you hire new people if you want to train them on some stuff. They also have samples of like what your staff manual with your infection control policies should look like as well. That is the end of my presentation. I don't know if there's questions. I'm looking to see if anything's in the chat. Let me look. I see nothing.
Well, thank you so much, Erin, for that very informative presentation.
Thanks, Dr. Bourne. He chatted in there. He's like, good job. I'm sure that, yeah, I was going to say, I'm sure somebody's going to post my email somewhere. I don't know if I can put it in here. Let's see. Optum One sprays are fine. Somebody asked. I typed in my email address into the chat. So if anybody wants to email me and get some of these resources, again, all these resources are available on the internet, but I know that sometimes like just looking for them can be like daunting. And so I have them easily available and I have no problem just emailing them to you. And like I said earlier, I do share the Snohomish County area with another colleague named Allie. So you might be hearing from both of us. Not in a bad spammy way, just we work together. You like the Seinfeld? I do too. When I do these presentations in an office, it takes like over an hour because obviously people are talking to me. But when there's no questions happening when I'm giving the presentation, it goes pretty fast. You can't see it in the chat. My email address is Erin sandra.gallegos@dentsupplyserona.com. And I'm sure that Sandra at Snohomish County can also email it. I put it in the chat, but I don't know if you can't see it. I don't. Oh, thanks, Louis. Please.
So if there aren't any other questions from attendees, we can hand the meeting back over to Dr. Tran. Thank you so much, Erin.
Thanks.
Thank you. Thank you everyone for attending. Just a reminder that our next meeting will be in person for the month of February. And also a reminder that the CE certificate will be emailed out in the first week of February. Thank you so much, everyone.